I realize there are only maybe two or three people in the world that don't know you, but for those two or three people, could you share a little bit about yourself and your
Sure.
background? That would
Yeah,
be
of
great.
course. My first name is Nahreen Ahmed. I'm a pulmonary critical care doctor based out of Philadelphia at University of Pennsylvania. And I do a lot of global health work, which is how I actually got involved with discussions with Butterfly, with all the amazing work that they're doing around the world. And I work with two nonprofits, with Med Global and Bridge to Health, kind of working with expanding ultrasound and its use in low resource areas and disaster response areas. This is it's a great pleasure for me to be here to chat with you.
So you have started and used ultrasound kind of from the very beginning in your training. It's been a big part
Yeah,
of who
that's
you
right.
are.
Yeah, that's right. So I trained at NYU in New York City, and we had a amazing training up there in which Paul Mayo had led a group where in the summer of our first year of fellowship, all the Palm Crit Care fellows from New York actually were gathered together for a week, and sort of had a boot camp in ultrasound training. And then we were very lucky to have several of those experts at NYU. And so throughout the 3 years of my fellowship, I had pretty significant ultrasound training, and graduated as an ultrasound competent physician, which was great because I was able to come to University of Pennsylvania and really help build the critical care division ultrasound training down here.
If you think about this time in history, it's quite fascinating. You go back to 9/11. I would say it's interesting to see now this is the 9/11 moment for healthcare workers.
Yeah, I would agree. I think I'm incredibly proud of the profession that we're in, and day in and day out, we go into work, even well before this pandemic, and with any other epidemic that happens. I mean, during flu season, it's the same thing. We really think about putting patient care first and making sure that we're protecting those that we treat. This is just a bigger stage for that, and to really think about how we can do our part. I mean, many of us, we're running into that room when the patient's sick and doing everything that we can to treat them and to make them better and to create a positive outcome. This is no different. It's just with a little bit of a higher risk. And I know I can speak for every one of my healthcare colleagues that we are up for the task. We just want to be able to do it safely. And I think it's incredible to see the outpouring of love and support from our friends, our family, and the community. And that's just so incredible. And we hope that that support kind of also extends into the arena of mental health support and healthcare supplies and things like that, where I think the effects of this is going to be very long lasting on our community as healthcare providers. And so that's something I'm uniquely very interested in at this point, to kind of see how we can boost the support in any way possible, and to really try and mitigate some of the long term outcomes.
So there's sentinel moments in history that define a generation, if you will, and you see people talking about the greatest generation. Well, this is that moment for us, for sure, for the world. I think I've certainly seen an outpouring around the world of a collective, at least in the medical field, of sharing and ideas across the platform. I'm kind of hosting, and this, on the middle of this group think, if you will, and it's amazing how many different countries and different physicians are now involved, and I think it's a really special time for us to learn. So let's use this opportunity then to share what you know. I know, as you said, you're in Philly, you're close to New York, you have New York roots, and New York's getting pounded, and all of our hearts are there. But you're close to New York. I mean, and you're a New York affiliate, if you will. It's the big stop before New York
Right.
when you think about it. And you have probably, if you look across the country, but about 800. I think I just looked at the Hopkins Matter, 850 right now cases, but
Right.
growing rapidly.
Yep, that's right.
Um,
I believe in the last day had increased by almost 200 cases, and that number of increase per day is going up as well, and that's certainly something that's worrisome. And as we see the numbers increase in New York, we have plenty of very intelligent people working on models to kind of figure out what is it going to look like for us in several weeks. And I think we're a couple weeks behind the New York City curve, and hopefully it doesn't get to that extent with some of the measures that have gone into play from the local government to kind of shut everything down, shelter in place, and things like that. But it is concerning to see the numbers continue to increase, and we're doing our best to kind of take a chapter out of the book from our New York friends to see how we can prepare our hospitals and our healthcare workers.
so that leads me perfectly in the next question. What are you doing to get ready? Let's think of both the logistics perspective, how
Mhm,
are you organizing yourself in both the decision making mode, who's making the decisions,
mhm.
the structural things you're putting in place to run patients through, and maybe from a technical place of how you're determining who should go home and who should come into the hospital. Can we walk through those?
Sure, that's a great question. So, first of all, hospital leadership has been incredible in our local hospitals here. And I can say, just speaking with some of my colleagues up in New York, it's very similar, where the administration has really gotten involved in determining who's the point person, who's the lead, and how we then delegate tasks from there. And those tasks include one, determining all the safety practices. So, what exactly should we be using for face masks and protective gear, the PPE? How much of it is available, and what are we doing in order to mitigate that shortage? And then of course dealing with the space in hospitals. How are we able to manage these patients and cohort them in areas so that we're not spreading COVID patients across the hospital and putting others at risk? And so these kinds of policies are being developed by our hospital leadership, and each division is sort of working on their own policies, and then coming together as a hospital as a whole to kind of put that together and integrate that, because there are so many disciplines, so many departments, and that kind of leads into the issue of those that are actively performing clinical work or involved in some of these policies and emergency responses, or those that are coming to work. Those that are maybe non-clinical, which today I'm a non-clinical person, which means I'm not caring for patients today. I was last week, and it makes the most sense for me to be at home working from home while I continue to help with emergency preparedness for the hospital. So really every hospital is really coming up with this decision making group that leads with a supervising point person, and then kind of tasks delegated from there. And that includes everything from the safety of the patients to the safety of the healthcare workers, to space allocation. Where are we putting these patients? Surge capacity, thinking about, okay, if and when we get to the point, because we have to kind of think about it as if we may hit that point of surge. What do we do with our patients? Where do we put them? How can we turn all of our ICU rooms into negative pressure rooms? How can we expand into non-ICU areas? How can we train our colleagues who are non-critical care physicians into critical, those who almost everybody in medicine has had exposure with ICU, but how do we help support them as we expand into non-ICU areas? Those kinds of things are what's being done across hospital leadership, and it's incredible to see the mobilization.
But it's an interesting thing because there are some fundamental basic elements where everybody can help. And I think this is that time where we pivot and look back toward our basic education, which we all emerged out of, and leverage that. Specifically in the emergency room, let's use your place as an example. You obviously have people that come in with respiratory symptoms, and I candidly, for me, those are easy because we quarantine them off quickly. The ones that are scarier to me are the ones that are probably carriers that come in with a broken ankle because they fell, or they have chest pain, for instance, who nobody's initially thinking that this is a COVID problem. How are you managing those right now?
So, it's hard. I will say it's very difficult. In general, nationally, this is a problem. But I will say this because this is an opportunity to kind of advocate for it. But the ramping up of in hospital testing is probably the way to really address that issue. We have to risk stratify the best that we can, so we can preserve those tests for those that we really need to know. But really, in flu season, for instance, we pretty much test everybody, and that really should be the same concept that we're using here with the COVID-19 pandemic, because that asymptomatic transmission, that's a high risk time, and I think it's important that we know who's positive and who's not.
But you're
But
you're
certainly
you're seeing
stratifying.
all those, yeah. So you're seeing all those patients though, protecting yourself, assuming everybody that walks through the door is a carrier now. Is that the approach you guys are taking?
That's what we're attempting to do. Certainly, the shortage of masks makes it difficult. Persons under investigation, what we call PUIs, are where we're going into the room properly gowned with masks and things like that. If the suspicion is quite low, and the risk is quite low for any exposure, then in that particular situation, we may not be entering the room properly masked. And again, it's about risk stratifying and trying to do our best in preserving the supplies that we have at this point. And I think that's a hard thing for us to grasp as those that practice in the U.S. I have a lot of experience practicing in low resource countries, so
Yes.
it's a lot easier for me to imagine this concept of resource of really resource utilization and trying to preserve what we can.
How
Strategy
do
that
you triage patients? You know, there are obviously the extremes that they're profoundly hypoxic and dyspneic and respiratory distress. They come in, they're easy. If they're 20-year-olds with a sniffly nose, we know those go home. How do you do that group in between to decide to use those valuable resources inside the hospital versus you feel comfortable monitoring them in the home?
Yeah, so that's a great question. So especially with this pandemic, I think what we're seeing is that the hypoxia, that low oxygen levels that we see in the patients, it drastically gets worse and very fast. And oftentimes, what we're seeing is that the patient themselves may not look as sick as their numbers actually do, and even though they may not appear as sick, that low oxygen level, and as that continues to decrease, those patients need higher level of oxygen therapy and mechanical ventilation much more quickly than what we see in patients who are able to mitigate with things like non-invasive BiPAP, high flow nasal cannula, and things like that. That makes this particular triage strategy very, very difficult. And what we're seeing is that we know that younger patients with a higher pulmonary reserve will likely do a little bit better, even with a slight amount of hypoxia, meaning 1 to 2 liters of oxygen. However, those patients that are older than 65 with cardiac comorbidities, we're also seeing that there are a few other things that kind of portend poor prognosis, things like lymphopenia, low white blood cell counts, and other comorbidities that play into this that give us a clue that this particular person who is requiring 2 to 3 uh, liters of oxygen may be somebody we have to keep a closer eye on. And if they continue to get worse, even if they're not as tachypnic with that high respiratory rate, then that's somebody that we would consider putting in the ICU because the risk of them crashing quickly is very high. So it is challenging, and it's really identifying those patients with high comorbidities who are with escalating oxygen requirements, and of course, imaging is part of that as well. To what degree is still something we're all trying to figure out.
Yeah, I've heard a lot, particularly from the Italians, is a great example, and they've been, you know, advocates of lung ultrasound for a long, long time, and most of the really good literature actually comes from them. There's this progression, which is fascinating. We know that hypoxemia, relative hypoxemia, happens. We know the deterioration is pretty quick. We know that there's a period where you kind of waffle a little bit. What the Italians will suggest is that there's some lung findings before the hypoxemia that tell you somebody is getting into trouble. And one of the tricks we've heard people do is a walking test, you know, where they walk people around and see how far they drop. That's another element. So if you think about it, it goes from bad lungs to walking test that's positive to hypoxic at rest responding to profoundly hypoxic. And the question for all of us is, okay, in the world of lung ultrasound, which is really debatable, where does that fit into the equation? And we have the extremes of don't really need it, what only except on people that are admitted so that I have a baseline exam to follow them with, to I like to use it on every single one because there are patients, particularly with comorbidities, that could surprise me. And I'm not that confident of my follow-up as an outpatient. So I want to use lung to help me decide, do they come in or do they not? How do you use it? And do you see that decision-making evolve?
Yeah, so I think it's difficult. I think using it in triage is very useful. I believe that that could play a part in maybe determining which patients maybe need to go to a hospital bed, a ward bed, versus an ICU bed versus maybe potentially in the outpatient world. I think anytime you're dealing with a patient that is on any amount of oxygen, you're automatically kind of stuck with admitting them, and it's a question of where should they go? The general ward, step down, or an ICU, step down is available. And so I think we're still trying to answer that question. But the thing that really nags at me a little bit is really also that balance of trying to reduce the vectors of transmission. And I think that create, I love ultrasound. I'm the first one to be using it on every single patient, but I do also think that we have to be cautious with recognizing, and we haven't answered this question yet, I don't believe, recognizing when it's the most optimal for utilization and when it's giving us information that may not necessarily change our management, and instead maybe the risk of using it and creating another vector of transmission is an important thing that we need to think about with all of the medical interventions that we're providing. So I think in triage it's great. I think that concept of utilizing it, the more we understand about the pathology and the radiologic imaging of this disease and the progression of it, I think the more I see a part ultrasound is playing with triaging patients from home to ER to inpatient to ICU. And that's where I see it being really useful rather than potentially a daily follow-up. I think it can be very useful in the concept of triaging from higher level of care to lower level of care, and being able to transition between those two. But again, we're learning so much, and that's on a day-to-day basis. This is so dynamic, but I do think that's where it plays the biggest role. And in everything we do, just balancing the risk and benefit.
Yeah, and I think about that a lot in this. And part of the question I keep asking, you'll see it appear on groupthink. One of the other things I'd love to be able to do is when we talk about lung ultrasound, we're pretty comprehensive in examining all the fields. The question really is could we develop a shortcut? Since we know that it tends to affect the posterior lateral segments more, how often could we get away with a quick peek in those segments alone, minimize our exposure, if you will, and that being enough to tell us, I got the information I need. I don't need to look at every single lung field. And the hard part about thinking about that and doing studies on any of this stuff is, we can't do this study in New York. They're trying to survive. So how do we find a place that there's enough going on, that we have a big enough end to answer the question, but not overwhelmed, where we can fit this kind of knowledge gathering into what we're actually trying to do? And I think that's a challenge.
Yeah, I agree. And I think this is where, I've always been so impressed by the Butterfly engineers, the tech teams. They're always coming up with these creative solutions. And I think this is a very unique opportunity to come up with a creative solution on how we can continue to image patients with ultrasound, but also minimize the risk of transmission and optimize the utility of what we're seeing. And there's a lot of talk about potentially using stickers where you place it on the patient and then you can transmit those images to the Butterfly itself, and thinking about contactless ultrasound and things like that can be utilized into the system. And I think this is where we as healthcare providers, with our collaborative tech companies, are really thinking, how can we get creative on how to provide solutions in this type of a scenario? And I think that's, this is why it's so great to have these conversations and to think about how we can get over some of these obstacles, collect more data, and create some innovative solutions. It's been great to see the images from those that have a Butterfly at home and are sort of self-documenting, because that information is incredibly useful in that scenario where how can we triage patients, and regarding whether they should just stay home or whether they should come into the hospital, in a setting of thinking about, in my mind, I just keep, as an ICU doctor, I just keep going back to the fact that the American Hospital Association has quoted something like 85,000 ICU beds for adults. And just thinking about that with the projected numbers of how many people might actually require an ICU bed. In the New England Journal released a great article this past week that was kind of quoting the moderate numbers. If 5% of the population gets infected, we're looking at up to 960,000 patients that may require ICU beds. And again, that original number of how many exist is 85,000. How do we kind of fix that math, right? And it's really thinking about, how do we preserve the number of patients that actually need those beds? How do we triage? And this kind of study is really important on how to really triage patients to who can stay home and who actually requires being in a hospital, because those resources are scarce if you really think about it.
Yeah, and I think this is, and we've been very, and I appreciate you saying nice things about Butterfly. We do appreciate that. But one of the things that we feel very strongly about is this is the time for handheld ultrasound. So we can pick whatever devices you're fancy. We're perfectly happy, standing up to others, but also recommend the fact what's most important to us at Butterfly, and this is something that we're all trying desperately to do. This is getting the message up farther up the food chain, if you will, on a national level, to say, for places that aren't familiar with using lung ultrasound, either if you're not going to use it in triage, you're going to want to use it somewhere in the course of this illness. It's incredibly helpful. And you are one of those relatively rare people that has really good skills. In the community hospitals around the country, there's not 10 people like you working there. And I'll use our good friend Jimmy in England, or Johnny, excuse me, and he's taking this moment in time before they get hammered, training everybody. Mm-hmm. And I think that that's a really important message that hasn't gotten to the top. Yes, it's about ventilators. Yes, it's about masks and gowns. It's also having your people ready to know how to manage this going through. And I think one of the greatest lessons for me I've learned is the variability around the world of how people are doing this. And it's almost somewhat like we're doing it in a vacuum. that every little place, and while we know there's some uniqueness to every location, there are some lessons learned that got to quickly get across. And yes, it's about finding a drug, and yes, it's about finding a vaccine, but it's also, hey guys, what's the best protocol that we've seen around the world on how you would manage them going through? Let's talk about that. And that conversation is not happening.
Yeah, yeah, I would agree. I was on a fascinating webinar with Neelam Soni yesterday, who is fantastic, kind of talking about the lessons we've learned in ultrasound so far, and really talking about what are some of the findings that are useful for us to know in this particular pandemic. Certainly, of course, lung ultrasound being at the top of that, but also thinking about basic cardiac ultrasound and the development of cardiac arrhythmias in this disease process that happens near the end of it. And also, we had a doc that called in from Long Island Jewish, who was talking about how thrombogenic these patients are and how a DVT exam is really a regular DVT exam is somewhat useful. Now, how much of this is in a protocol of some sort, not really quite yet, because it's still at that experiential phase of all of us knowledge sharing with the experiences that we're having, and really trying to help each other out with what's useful. But I agree. I think there's still a lot of discussion to be had. And I think there are a lot of people out there that have had some incredible experiences, and kind of putting those heads together to really come up with what ultrasound exams are of high utility and that can really help us with management, and really trying to figure that out and come up with some kind of way to teach that in an easy way. That's always been my platform, is how do we make this teachable, so that we can create experts from novices. And I think that discussion is very much in need as well.
Yeah, and I think you have that expertise because you've literally traveled around the world doing exactly that. And there are lessons learned from what you, and so what we're looking for is people like you to get to the top of the food chain. I was really thrilled to see Eric Topol, who has a massive following in social media, bring up that Lancet article that just came up that hopefully, raised some eyebrows. It's really literally every single day there's another paper about ultrasound and its role. And I think if we can get people like you together at the leadership level around the country, and maybe I'll look in the press conference one day and see you standing there, which would be great. You and Dr. Fauci can sit there and talk together about how ultrasound could be used. That'd be terrific.
Yeah, I think I do think ultrasound plays such an important role in medical management, even outside of this pandemic. The thing I would just be most cautious about is, what we're finding is proper hand hygiene, PPE, and sanitation is what works. So, really making sure that we're pushing that as well, that if we're going to be bringing another device in the room, that we just have to make sure we're also being, using our common sense about what that means with droplet spread onto the device, and really making sure that we're good about cleansing them. And, and that's been, people are working on that. I know Butterfly already has kind of put on their website about the sheath that could be useful as well. All of these things are fantastic thoughts, so that we can continue to use a very helpful tool for our medical care.
Well, I think you get back to what we talked about earlier. It's all about discipline. This is a moment in time where you just have to be disciplined about all of this. And you have to imagine everything in that situation is infected. Everything could be a vector. And how do I make sure that's not the case? Well, I think we'll close here for a moment, but I will invite you back, because I think part of the next conversation will be how have we evolved, through the crisis with you? What have we learned about how we've educated people? And hopefully we'll get the opportunity to talk about how education has broadly gone. And then I do want to keep going with this okay, it's now post-COVID. Mm-hmm. And I think one of the byproducts here is the world's going to figure out lung ultrasound is great. And what we don't want to have happen, which I think would be a great travesty of this, is a whole bunch of people learn how to do lung ultrasound and then think they're done with it when COVID goes away. Because it's such an important tool, and to have, whether it's for congestive heart failure or pneumonia or any of the other things, this is a moment for this to linger, and the lessons need to linger. And so we'll look forward to working with you on spreading that message as well.
Yeah, I'll end with this story. We had a patient recently with who was flu A positive. The X-ray was not really definitive as far as an infiltrate. We took the ultrasound to the bedside, and sure enough, there was a pretty dense consolidation in the right lower lobe. The patient had decompensated after supportive care in the first couple of days. It was pretty clear that he had a bacterial superinfection. The X-ray, like I said, was not nearly as helpful, and that lung ultrasound image is now seared into the brain of all the trainees I had with me that day. So I think it's important that we continue, as you said, to really push the need for ultrasound, well, very much outside of this pandemic, but also really thinking about ways that it can be useful to help triage during this. Because I think really keeping in our minds the utility of any strategy that can help us preserve healthcare resources. That's the utmost priority right now.
Now, Nahreen, are you open to people contacting you through your website if they got questions or concerns?
Absolutely.
Is
Yes,
there an email address you want to share that people can?
yeah, I think my Gmail address is probably the best. So Nahreen H Ahmed at gmail.com is the best way to reach me. And I usually have a pretty quick turnaround.
Yeah, so for those of you out there who are looking for an expert who really knows actually how to make the ultrasound sing, but is more importantly has a global experience in a broad range of areas where care is to be delivered, this is a person to turn to for help in this moment. So Nahreen, thank you very much. We really appreciate you being part of this. And well, like it or not, we're going to lean on you a lot more in the future.
I appreciate it. Yeah, no, absolutely. Let's keep the conversation going.
All right, thanks.